It's my pleasure to introduce Dr. Shadow Fan, who's a professor of psychiatry and director of the Psychotic Disorders Clinical and Research Program, who will introduce today's speaker.
Thank you, Tony. So it's my pleasure to introduce today's grand round speaker, Dr. Don Goff. Dr. Goff is the director of Nathan Klein Institute and also Marvin Stern Professor and the Vice Chair for Research in the Department of Psychiatry at the New York University Grossman School of Medicine. Dr. Goff came to New York from Boston when he had been director of the schizophrenia program at Mass General Hospital and a professor of psychiatry at Harvard Medical School. He is a native Californian who earned his undergraduate degree at the University of California, Berkeley, and his medical degree at UCLA. He completed his residency in psychiatry at MGH. Following his medical residency, Dr. Goff completed research fellowship in psychopharmacology at Tufts New England Medical Center. At MGH, Dr. Goff built a translational research program with expertise in pharmacology, genetics, imaging, cognitive neuroscience, and the cognitive behavioral therapy. Dr. Goff has been the principal investigator for many studies concerning the treatment and the management of schizophrenia. He is currently focused on early intervention strategies in schizophrenia and immunological findings related to increased COVID mortality in schizophrenia. During his 10-year tenure as Vice Chair for Research, the NYU Langone Department of Psychiatry has risen from 18th to 3rd in the Blue Ridge Institute ranking of U.S. medical schools in federal funding. Dr. Goff has published over 300 articles concerning schizophrenia and the related topics. He was the recipient of the Kemp Award for Mentorship in Biological Psychiatry from the American Psychiatry Association, the Wayne Fenton MD Award for Exceptional Clinical Care, and the Stanley Dean Award for Research in Schizophrenia from the American College of Psychiatrists. He is also a member of the American College of Neuropsychopharmacology. Today, Dr. Goff's the topic for Dr. Goff's grand round talk is new pharmacological approaches to early psychosis, taking aim at the hippocampus. Dr. Goff, please.
Great. Thank you, Shadow and Tony. It's great to be back here with old friends, and it's wonderful to see all the construction outside and knowing that UMass continues to expand, and it looks very like a very vigorous institute here. So it's really nice to come visit again. Also, I must say, I met in the previous hour with the residents, and Bogdan Anton did a wonderful presentation. I really enjoyed meeting with the residents, who were just a very bright, interactive group. So whereas the last hour was practical, and we really talked about the treatment of early psychosis, this talk is going to be sort of more theoretical, a little self-indulgent. I'm just going to be talking about some questions that have captured my interest over the last 5 to 10 years, and some studies that address some of these questions. Yeah, okay. And so let me, in terms of, first on no disclosures. So the overall, what I'm going to be talking about is just the sort of fundamental question that I got stuck on about 5 to 10 years ago about whether antipsychotics are protecting the brain against psychosis and neurotoxicity, or whether antipsychotics themselves may have neurotoxic effects. Just a very, very sort of simple, basic question, which is still unresolved. In terms of why today's lectures are focused on the hippocampus, early on we chose the hippocampus as sort of the canary in the coal mine, the hippocampus being particularly prominent in terms of volume loss early in psychosis, very vulnerable to stressors, oxidative stress and immune toxicity. And so we really early on focused on the hippocampus as a potential measure or proxy of neurotoxicity. Based on the early work, our first intervention, which I'll talk about, was with citalopram, an SSRI antidepressant, as a way of increasing BDNF to protect the brain. So I'll discuss that study, and then a study which, today I only have pilot data from, but a program in progress looking at levetiracetam. So the story really starts with this paper. So if the topic is of interest to you, I would refer you to this paper, which was in the American Journal of Psychiatry 5 years ago. And that is, it's surprising that 70 years after the introduction of chlorpromazine, we're still debating whether over the long term antipsychotics are helpful or hurtful. And the consensus has always been, and I'd say continues to be, that we should initiate treatment as early as possible with as low a dose of an antipsychotic as possible, try to avoid relapse, but not to use antipsychotics unnecessarily. But there is, and a lot of this is based on work suggesting the longer that people are left untreated, the worse the eventual outcome, so-called duration of untreated psychosis. On the other hand, there's a lot of data from animal models and from imaging showing an association between cumulative antipsychotic exposure and brain volume loss. And we can't be certain of causality about that, but there is also concern about whether over the long term antipsychotics are actually also deleterious to the brain. So this paper presented the evidence and concluded that we need placebo-controlled trials to really be able to sort out illness effects from antipsychotic effects. But I'm going to talk about at least 3 studies that I think begin to address this question, although it still, I think, is quite unresolved. So I started by being really intrigued by the literature on duration of untreated psychosis, or DUP. And this is a much cited meta-analysis that looks at the association of duration of untreated psychosis and outcomes. So in the first, can you see the cursor? Yeah, okay. So up in the top, you see the association between symptoms, psychotic symptoms, negative symptoms, functional symptoms, and duration of untreated psychosis, that the time of presentation is not significant. So when patients first present, DUP is really not a predictor of presentation, but it's only after treatment is started. So this next cluster is 6 months after initiation of treatment. So we see then after antipsychotic treatment, 6 months into it, the relationship is significant. It's small to moderate effect size, but nevertheless, longer delay of treatment is associated with worse outcomes, positive symptoms, negative symptoms, functional symptoms. And then that continues out 12 months and further still, although the numbers are smaller for longer periods of duration. So this is puzzling. If untreated psychosis was just generally not neurotoxic, you would think the longer someone had been ill, the worse their symptoms would be on presentation. That doesn't quite seem to be the case. If it's only apparent after treatment has started, to my way of thinking, it suggests 2 possibilities. One, which is kind of sort of the general explanation, is perhaps people are less responsive to treatment. So if someone's been psychotic for 5 years and only then you start the treatment, perhaps they don't have as good a response as if you had initiated it early on. That I think makes a lot of sense, and in fact may be true, although the negative symptoms and symptoms that we don't think of it as being antipsychotic responsive are equally predicted. So that's a little surprising. The alternative explanation, and I think I'm the only person who entertains this possibility, is perhaps the initial the initiation of treatment might be in some way neurotoxic, and that the longer you've been psychotic, the more vulnerable you might be to an initial toxic effect of antipsychotic. And the reason for that is when you start an antipsychotic, it blocks presynaptic autoreceptors and results in a flooding of dopamine. So by blocking presynaptic D2, the VTA dopamine neurons are become very active and release a lot of dopamine. And dopamine and its metabolites are in fact neurotoxic, cause oxidative stress. So there's a theoretical rationale for why that's even worth considering, although by no means do we know that that's the case. So to look at this, the question of what's going on when you first start the antipsychotic, why does DUP become relevant, not at time of presentation, but after the antipsychotic has initially been treated? Does DUP kind of influence the course of the illness directly, or is it an interaction with some potential neurotoxic effects of starting antipsychotics? So to do this, I worked with my long-term collaborator, Zhizhong Wang, in Shanghai Mental Health Center. Zhizhong spent 6 months with us. Shadow, I think you were there in Freedom Trail, yeah. So back 15 or 20 years ago, and has been a wonderful collaborator ever since. So Zhizhong was able to enroll 70 medication-naive first episode schizophrenia patients, and then 70 very well age and gender-matched healthy controls. And what we did is a very simple design. So we took these medication-naive patients, did clinical assessments, we obtained blood for biomarkers, saliva for cortisol, and then we imaged them to measure hippocampal volume prior to starting the medicine, and then 8 weeks after they had started the antipsychotic. And then we had a healthy control group that we followed. They didn't receive antipsychotic medicine, but just to see the natural course of our biomarkers and the hippocampal volume assessment. The way we measured hippocampal volume is very important in that this is different than most of what you see in the literature, which is free surfer estimates of hippocampal volume. So my colleague Babak Ardakani at NKI devised this method by which there are about 300 landmarks in the brain, and he uses artificial intelligence using these landmarks to calculate in a given brain scan what the expected hippocampal volume would be in a normal brain, given those 300 landmarks. And then he measures the actual volume of the hippocampus, and then produces what he calls hippocampal volumetric integrity, which is the actual volume of the hippocampus over the volume one would expect in a normal, healthy brain. So that ratio is sort of the inverse of atrophy. So it tells you what percentage of the hippocampal volume is present at the time of assessment. As you can see down here on the lower right, because this is completely automated, has extremely high retest reliability. So it's extremely sensitive to picking up any change in atrophy. The biomarkers, I won't go through all of these, but be happy to talk later about any of them. But we chose biomarkers that sort of sampled every group of molecular processes that have been associated either with actual evidence or theoretically with brain volume loss. So it's inflammation, oxidative stress, excitotoxicity, meaning primarily glutamatergic mechanisms, growth factors, of which we only looked at BDNF, but there's a large literature on BDNF genotype predicting brain volume loss. Mitochondrial injury, which we use lactate, stress, we looked at the salivary cortisol and some related genes. And then dopamine signaling, peripheral measures aren't very good, so we just looked at genes related to dopamine metabolism, D2 receptor expression, and some of the intracellular pathway molecules involved in D2 signaling. So this is a collection. I'm always skeptical of studies that look at peripheral measures because of blood-brain barrier. It's very uncertain whether they really tell us much about the brain. But all of these measures and really have been shown to cross blood-brain barrier to be informative, and the genotypes obviously are more of a trait rather than a state measure of all of these. And the questions then we're asking are, first of all, is something going on in this early stage of treatment, which is why DUP becomes predictive? And so could we detect a loss of hippocampal brain volume in 8 weeks of treatment? And all the experts I consulted said, no, there's no way you'll pick up change in volume over 8 weeks. But given the sensitivity of this measure, and the fact that it's such a dramatic change in DUP prediction, we thought was worth the try. The second was, if we do find a change in hippocampal volume, is it related to DUP? Meaning, could there be some relationship in brain volume loss, neurotoxicity of some sort, which is why DUP may become predictive after the first few weeks. Then to sort out, is the hippocampal volume loss related to the illness or related to the treatment? We looked at our biomarkers, and the idea was, if the biomarkers that predicted hippocampal volume loss differed between patients and controls at baseline, that would suggest that there's something related to the illness that is increasing these factors that then produce hippocampal volume loss. So differences between baseline in patients and healthy controls would identify potential biomarkers that might account for the illness causing hippocampal volume loss. The converse would be if we saw a change with treatment from baseline to week 8 in the patients in our biomarkers, that might suggest that the antipsychotics are either producing a neurotoxic effect or a neuroprotective effect. And we would then look to see if those biomarkers predicted hippocampal volume loss. So the results in terms of hippocampal volume, so you see here, given this very sensitive measure, a highly significant difference at baseline between healthy controls up here in blue and patients in red. So at presentation, there was a sign of significant hippocampal atrophy. The healthy controls had a slight increase in hippocampal volume, consistent with what we know about brain growth at this age. The patients had a significant loss of hippocampal volume in just 8 weeks, really dramatic. So if this were to be annualized, so if they continued this rate of hippocampal loss over 12 months, that'd be somewhere around 5 to 6% loss of hippocampal volume. So if this continued, that would be a very substantial volume loss. So seeing this, the immediate conclusion is the antipsychotics must be neurotoxic. How could you lose this much volume in just 8 weeks? However, out of curiosity, we tried extrapolating back. So this is not actual data. This is just following the slope of these two lines. And turns out they converge at exactly the mean duration of onset of psychosis, meaning the DUP, the mean DUP for this group was 23.9 weeks. So meaning on average, psychosis started right at this time point. And that just means that this slope could be consistent with volume loss if it started with onset of psychosis. So it's a bit of a paradox. We're seeing volume loss with 8 weeks of treatment. We can't say for certain whether this is just continuation of volume loss associated with the illness or whether this is new volume loss resulting from treatment. And I think one important point is the heterogeneity. This again, the y-axis is, the x-axis is the DUP, duration of untreated psychosis. So this is 0. So this is the mean age of onset of psychosis. Actually, the onset of psychosis for each of these individual patients. And you see the 2/3 of the patients started with within more or less normal hippocampal volume and stayed the same. There is this subgroup that had steady increases with DUP as we go out on the DUP axis, which are consistent with this onset starting at onset of psychosis. And then there are these two individuals. So this is only 10% of patients who started at relatively normal hippocampal volumes and had by far the largest loss of volume. So if these were annualized, that would be up in the 20 to 30% volume loss group. So suggests that some patients may be impervious to hippocampal volume loss. There may be one group that have associated with illness, steady hippocampal volume loss, and a very small number of patients who possibly have a antipsychotic related volume loss. Again, highly, highly speculative, but things to look at in larger samples in a replication study. So we did find that DUP predicted the change or loss in hippocampal volume. So that was highly significant, predicted account for about a third of the variance in hippocampal volume. And then the biomarkers were very puzzling, very confusing. And that is that at baseline, the patients and the healthy controls didn't differ, with the exception of cortisol was elevated and aspartate was slightly elevated in patients. But we expected to see dramatic increases in inflammation, oxidative stress at baseline. We didn't pick that up in patients compared to healthy controls. It's interesting that in China, there's essentially no substance abuse, in contrast, at least we're told, contrast to patients here, much less obesity. There may have been fewer confounding factors that may present with inflammation in US samples. And then paradoxically, there really was almost no change in our biomarkers with treatment. The one exception, which I didn't list here, I think I was in sort of a negative mood when I first made this slide, but turns out homocysteine was elevated. And if I were to pursue this, which we hoped in the future, the idea of homocysteine being elevated, I think may be very important. I didn't list it here because homocysteine didn't predict hippocampal volume loss, but homocysteine highly predicted increase in oxidative stress and increase in inflammatory changes. So homocysteine is a byproduct of dopamine metabolism, and homocysteine itself is neurotoxic through NMDA receptors. So the elevation, which I don't mention on the slide, of homocysteine may be important. It itself didn't correlate with hippocampal volume loss. But the important message is a lot of these factors, immune factors like IL-8 and related inflammatory cytokines, and oxidative stress and BDNF genotype, and some measures indirectly of dopamine metabolism and glutamate all interacted with DUP to highly predict baseline left hippocampal volume. So these biomarkers didn't differ between patients and healthy controls, didn't really change with treatment, and yet they still highly predicted loss of hippocampal volume, and they interacted with DUP. So the relationship between DUP and potentially poorer outcomes involves these biomarkers, but it sort of suggests that patients may be more susceptible to oxidative stress and inflammation, but may not necessarily have more of it than healthy controls. And then the same was true in terms of the change. So the previous was at baseline, factors accounting for smaller hippocampus. Change over 8 weeks is mostly measures of oxidative stress. And again, nitrous oxide, which Shadow is very interested in studying, which is an interesting compound that's related to NMDA receptors and to inflammation and oxidative stress. So these factors, again, interacted with duration of untreated psychosis to predict change in hippocampal volume. So sort of to conclude about that, and I'll return to this idea, is that we are seeing hippocampal volume loss during those first 8 weeks of treatment. It interacts with duration of untreated psychosis to predict hippocampal volume loss. And the biomarkers, the ones that we sort of predicted, BDNF, inflammation, oxidative stress, all seem to be at play, but they're not affected by the illness or the drugs. So possibilities are, one, patients with schizophrenia are more vulnerable to inflammation, oxidative stress of other causes, say environmental causes. And also, the one thing that we did see that changed with treatment, which was homocysteine, that may be an intermediary effect of antipsychotics. So patients may be losing brain volume before treatment due to other factors, these other factors I mentioned. With treatment, there may be no change in biomarkers, but homocysteine may be part of what's making patients more vulnerable to some of these existing factors. And we'll and that would be through the mechanism of increased dopamine release. So since that was done, there've finally been 2 placebo-controlled trials is what we really need. And that kind of helps us sort it out. So in one of the 2 papers in the introduction, they had these figures. And I think it's a nice illustration to show the different possibilities in terms of how you account for brain volume loss in first episode schizophrenia being either related to the treatment or being related to the illness. So in this diagram, I guess that's, what color is that? Is that gold or orange, whatever? So the orange line is one possibility, which would be brain volume loss due to antipsychotic treatment with healthy controls and placebo-treated patients the same. Or it could be that it's the illness. So whether a patient gets the treatment or the placebo, they would both show loss of volume loss. And in the absence of the placebo group, our data looked like this, and we just don't know if it's illness or treatment or a combination of the 2. So I'll show you examples of all of these. This is another possibility, which is an actual increase of volume with antipsychotic, and I'll show you an example of that as well. So the first, and we have Tony Rothschild and his colleagues to thank for this very important paper. The first paper, the clinical report, was in JAMA in 2019. And basically they took elderly patients with psychotic depression, stabilized them until they remitted with an antipsychotic, olanzapine plus an antidepressant, sertraline. Then after 8 weeks, when they were remitted and stable, they then, under double-blind conditions, stopped the olanzapine in half of the patients and continued it in the others. And you can just see the very important finding that stopping olanzapine in these patients led to a psychotic relapse at a significantly higher rate. When I was a first-year resident, one of the first patients I treated on the inpatient unit was an elderly psychotic depressed woman, responded well. We discharged her, and then her outpatient psychiatrist stopped the antipsychotic, a few months later, and she actually died of suicide following that. So for me, I take this finding very sort of personally in terms of I've often thought about that case and how troubling. So this really documents the importance of continued antipsychotic use. But the reason I'm mentioning this study is they then published a second paper in JAMA Psychiatry looking at brain volume after discontinuing olanzapine compared to patients who stayed on olanzapine. So this is a 9-month follow-up study. It's one of the very few examples we have of a long-term placebo-controlled trial of medication-free versus medicated patients. It's not schizophrenia, it's psychotic depression, but still we can learn from this. And basically, they found 2 things of interest. One is, and this is total gray matter volume, or I'm sorry, cortical thickness, correlate of volume. They found that both on left hemisphere and right hemisphere, olanzapine was associated with loss of cortical thickness or loss of gray matter volume. But in addition, those patients who had a psychotic relapse also had loss of gray matter volume. So again, this goes back to the idea that both the antipsychotic may be causing brain volume loss, but also psychosis itself may be associated with brain volume loss. We can't conclude that the brain volume loss is always pathological, is always problematic, but nevertheless, again, this supports the argument that we may need to think in terms of both of these processes may be contributing. And then the other placebo-controlled trial, which is difficult to interpret, but nevertheless, I think of interest. You may have heard there's a study recently in Australia, which is the first study to try withholding antipsychotic in first episode psychosis. So they took 81 medication naive first episode psychosis patients, randomized them to antipsychotic treatment versus placebo, and all patients got a fairly comprehensive psychosocial intervention. And these were patients who were relatively stable and seemed to be fairly low risk for suicide or aggression. And the study got a fair amount of press because they found no difference between antipsychotic treatment and placebo in these patients. But I'm not presenting it because of the outcome, because as I'll show you, it's difficult to interpret, but at least it gives us one more example of a placebo-controlled trial because they looked at brain volume in these patients. The reason it's hard to interpret is, one, if you look at who was in this study, less than half of the patients actually had schizophrenia or schizophreniform disorder. So it was a mix of substance-induced psychosis and a lot of different forms of psychosis. So we can't really generalize, I think, about treating people with true schizophrenia. And the other issue is that less than a third of the patients made it through the entire study. So a huge dropout rate, a really heterogeneous group of patients. So it's hard to know how to interpret it, other than the fact that, to be aware that there is some evidence that some patients may do okay without antipsychotic treatment. But the finding I wanted to just mention is, in the small group of patients who survived at 3 months, they looked at total brain volume. And as it turns out, patients who were untreated had a loss of brain volume, reflected by this blue line. Patients who received olanzapine had an increase. And this was all entirely based on one small region of the brain, which was the right globus pallidus. And so it's an example of antipsychotics. In this case, the increase in globus pallidus volume was associated with good outcomes. And in this case, patients who did not receive treatment and had volume loss were more likely to have poor outcomes. One thing that's of interest to this, so we've done a lot of work looking at circuits related to psychosis. And when we look at functional connectivity, it's exactly this same spot. In our studies, it's the right lobus pallidus interna that highly predicts predicts psychosis, antipsychotic response. It changes in correlation with antipsychotic response. So there's something about the globus pallidus interna that seems to be important. But again, this is the one other example of placebo versus antipsychotic, in this case showing a regionally specific increase in volume. So let me just some conclusions, mostly because nothing of what I've said really has any clinical relevance at this point, but it's more theoretical. But based on these findings, I think just on the sort of the general literature, it looks like that not all patients require long-term antipsychotics. Maybe 20% manage to go long periods of time after initial stabilization, but there is evidence that stopping antipsychotic is associated with longer-term worsening, that patients don't always return to where they were. And to the extent that we think at first presentation something's going on with the initiation of antipsychotic and we see hippocampal volume loss acutely, that may be true with each relapse. So given concerns about antipsychotics, best not to use them unnecessarily, but you should really do whatever you can to avoid relapse, because there's a real cost to relapse. And as I said, there's some evidence going both ways. Most of the evidence is that psychosis and the illness is associated with volume loss. Antipsychotics may also produce some volume loss. We can't conclude for sure that that's necessarily deleterious to brain function. And so those are kind of the only, I think, relevant messages. In the next study I show you, it has some implications also. So the next study was, so that was just the first 8 weeks of the treatment. Something's going on. We're seeing volume loss related to these biomarkers. We then wanted to choose one biomarker that would have implications for treatments. Could we protect against volume loss? And we wanted to see, does this dramatic loss of hippocampal volume over the first 8 weeks, does that persist during maintenance treatment? So we decided to look at patients after they were stabilized, follow them for 1 year. And we chose citalopram because in our study and other studies, BDNF genotype has really highly predicted volume loss. So brain-derived neurotrophic factor is very much sort of protective and associated with sort of neurogenesis and seems to be associated with less vulnerability for gray matter loss. So in this study, again, was with our colleagues in Shanghai. We recruited another site in China in Changsha, and then MGH, and then by that time I had moved to NYU. So we had 2 sites in the US, 2 sites in China, and we took patients who were stabilized on antipsychotic, and then we randomized them to add on citalopram versus placebo and followed them for 1 year. And so the first finding was, we want to see, would this prevent continued hippocampal volume loss? And it turns out there was no difference between placebo and citalopram. But that was because there was no significant change in hippocampal volume during this 1 year. So it just shows that after stabilization on antipsychotics, hippocampal volume pretty much stabilizes for the next year, whether you get placebo or citalopram. And several other investigators have tried the neuroprotective strategies in first episode patients, and all these studies are finding there isn't any subsequent volume loss in the first, say, 3 years. So that seems to be early on and then further out on the illness. So our first question of whether citalopram was going to prevent progression of hippocampal atrophy, we couldn't really say anything because we didn't see hippocampal atrophy after stabilization on antipsychotic. So if antipsychotics are associated with some volume loss, we can say it looks like they're neuroprotective after this initial 8 weeks. And it just may be their neuroprotective effect is delayed, and this effect is more illness related. We can't conclude either way. And this finding that we don't see further atrophy for the first year is sort of consistent when you look at epidemiologic studies of first episode patients. This is the Suffolk County Mental Health Project, and patients tend to do well for the first 4 to 6 years after initiating treatment, but then there's this very worrisome downward path. In this, the blue line is schizophrenia, this is bipolar, and this is psychosis, NOS. But generally, patients do well for the first 4 years or so, and then there's this downward course with worsening negative symptoms, worsening functioning, worsening of psychosis, on average after about 4 years. So that probably makes sense why we didn't see a hippocampal progression during our 1 year. The other question we had was, in our first study, finding that there was no difference between patients and healthy controls in oxidative stress, inflammation, but nevertheless, those predicted hippocampal volume loss, was the question, could patients be more vulnerable than healthy controls to these factors, even though they didn't differ in terms of their absolute levels? So this study design allowed us sort of a natural experiment, and that is, in case you've not seen the literature, there's a really burgeoning literature on air pollution being a cause of brain oxidative stress and inflammation. And it's a real concern. Air pollution is now being linked to Alzheimer's disease and a lot of different neurologic and psychiatric illnesses. So as it turns out, you'll all be pleased to know that Boston and New York rate very low in terms of, you can get measures, annual measures of the particulate matter 2.5, the small particulate matter that's most associated with neurotoxicity. And Boston and New York ranked very low in the safe region in terms of air pollution, measuring PM 2.5. And this is Shanghai, which is much higher, and then Changsha, which is higher still. So when we looked at hippocampal volume change over this 12-month period, even though there was no net change as a group, when we looked at it in relationship to air pollution measures highly predicted hippocampal volume loss in between these 4 sites. So again, the R squared of 0.36 account for 1/3 of the variance in hippocampal volume. So this is consistent with the idea that patients may be sensitive to oxidative stress and inflammation, not necessarily from the illness, but could be from environmental contributors. The other hypothesis that the first study raised was, if antipsychotics are initially causing a loss of hippocampal volume, could it be from this excessive release of dopamine for the first 8 weeks? So after about 8 weeks of increased release because of D2 blockade at the synapse, then there's what's called depolarization block. And the dopamine neurons sort of become silent and stop releasing dopamine. So given that, we thought it turns out that drugs like aripiprazole, so partial D2 agonists, because they're partial D2 agonists, don't have that same effect. So you don't see the same immediate, high level of dopamine release during the first 8 weeks. So if that hypothesis were true, and it kind of ties in with the idea that homocysteine was elevated, homocysteine's, again, a byproduct of dopamine release and metabolism, and the homocysteine was associated with oxidative stress and all that, we would expect that aripiprazole might have been associated with less hippocampal volume compared to the other antipsychotics. And we actually did find that. So this is aripiprazole here during the first 6 months compared to all other antipsychotics, all of which were second generation, and then at 12 months. So again, they were not randomized, so it could have been confounded since it wasn't randomized, but nevertheless, we did find that patients who received aripiprazole had less hippocampal volume loss during that 12 months. Given that finding, and I should emphasize that this was published in the great journal of Clinical Psychopharmacology, my favorite journal, edited by Dr. Rothschild. And so given that finding, we thought, well, then, so that was from our second study, citalopram. So we went back to the first study and said, well, did aripiprazole differ in terms of its effect on the biomarkers? And that was also statistically significant. So this is aripiprazole, and this is all of the other second generation antipsychotics. And in all of these measures of inflammatory cytokines, aripiprazole was associated with lower levels. So again, neither of these were randomized in terms of treatment assignment, but nevertheless, it's consistent with the hypothesis that there may be drugs that are releasing dopamine early on may be sort of making patients more vulnerable to some of these factors, and aripiprazole may be protective in that way. As it turns out, citalopram did improve negative symptoms, but not related to protecting hippocampal volume. So there must be a different mechanism for that. Of note, it really differed in terms of whether a patient had a long duration of untreated psychosis or not, in that citalopram was associated with improvement of negative symptoms regardless of DUP, but patients with a short DUP had a big placebo effect, whereas patients with a long DUP had almost no placebo effect. Meaning, I think that the longer one has DUP, the less plasticity there is, the less patients are responding to being engaged in treatment, being engaged by research assistants. Patients' negative symptoms tend to get better just by being in a research protocol. But according to this, that's only true of patients who have short DUP. The longer DUP patients seem to lose that ability to respond to environmental stimulation. However, citalopram improved it despite the longer DUP. And then wanted to finish with the final topic. And so, as I mentioned, we've been interrogating a circuitry that we think is involved with psychosis. And, I'd be happy to, I mentioned the globus pallidus finding earlier that, that we find is highly correlated with psychosis. We're trying to target that with more neuromodulation strategies. But coming back to the hippocampus, there's one very prominent theory for early psychosis, and that is that there's a lack of inhibitory interneurons and a lack of inhibitory input to the CA1 subfield in the hippocampus. So a lot of imaging studies have suggested excessive activity in the hippocampus, particularly in the CA1 region in early psychosis. And it turns out that influences through an indirect pathway, it influences dopamine release. So it's sort of a positive feedback loop. So excessive activation of CA1 may be contributing to early psychosis, sort of a motor driving early psychosis, but it's also been associated with excessive release of glutamate and dopamine and neurotoxicity from this excessive activation, and so potentially causing volume loss as a result of excessive CA1 activation. So that's a model we thought that we could test. So in looking for compounds of how could we decrease excessive hippocampal activation, we came up with the idea of studying levetiracetam or Keppra, which I'm sure all of you are familiar. It's an anticonvulsant. It's rarely used in psychiatric patients because of concerns about causing aggression or hostility. It acts at synaptic vesicle glycoprotein 2A, which I'll talk about in just a second. But it decreases release of neurotransmitters, particularly in high activation state. So it's effective for epilepsy, probably because there's high activation and high release of glutamate, excitatory neurotransmitters. So it normalizes the activation level. And it's been found in patients with mild cognitive impairment to normalize excessive hippocampal activity and to improve hippocampal related cognitive function. So, so it seemed to be of interest. To say a little more about SV2A, again, as I said, it in high activation state, it inhibits release of neurotransmitters, particularly excitatory neurotransmitters. So that would seem to fit this model of people with schizophrenia having excessive release, excessive activation in the CA1 region. You come across SV2A a lot now because there's a PET ligand targeting it, and because it's located in synapses, it gives a measure of synaptic density. SV2A has been genetically linked to schizophrenia, which is of interest, and it's located in all the right places, the striatum, the hippocampus, the thalamus. To measure hippocampal activity, we used arterial spin labeling. So that's a technique by which you can measure blood flow. And the method we use, developed by someone at NYU, subtracts white matter, because white matter has about 1/3 the blood flow as gray matter. So if you have a loss of white matter, which is probably the case in schizophrenia, you could get artificial increase in hippocampal blood flow just on that basis. So we measure blood flow in the hippocampus, but we correct for white matter, and it's extremely highly reliable, quite sensitive. So I'm going to finish with this, and we have plenty of time for questions, so that's good. In order to do a drug study these days for NIMH, you need to, it's a two-part. So first, you can approach them with really no pilot data, just with a good idea, and so the first part is called the R6-1. You have to prove that your idea makes sense, that in this case, if we say we think levetiracetam would normalize hippocampal activity in people with schizophrenia and that might improve symptoms, you then have to prove that the levetiracetam is correcting hippocampal activity, it's lowering hippocampal activity. So that's the initial pilot study. If you prove that, then they allow you to go on to a large randomized trial to see if, in this case, levetiracetam would be associated with less hippocampal volume loss and better outcomes in terms of psychosis and negative symptoms. So I'm reporting a very small pilot trial. I originally wasn't intending to even publish it, but the results we found were interesting enough. It allowed us to proceed to the large trial that's going on right now. I think it's potentially informative, although be aware these are very small numbers. So what we did is we took initially 25 medication naive first episode psychosis patients, of which we have data from 21, in terms of imaging and all that. And then we took 10 healthy controls who were matched, and we measured their hippocampal blood flow before a dose of levetiracetam, and then after a dose of either levetiracetam 185 milligrams, 500 milligrams, or placebo, to see if the levetiracetam was affecting their hippocampal blood flow, and then also to see if psychotic symptoms improved. We chose 185 milligrams because that's roughly the dose that was effective in patients with mild cognitive impairment. And then we chose 500 milligrams because that's sort of a standard anticonvulsant dose. So our groups of healthy controls and first episode patients were well matched. They didn't differ in any way. The first finding was somewhat disappointing, and that was that at baseline, before medication, there was no difference in hippocampal blood flow between our patients and our healthy controls. We're going to go back and look at the data because we suspect maybe if we had not subtracted the white matter, that may be why some of these other groups have found differences. But recently, other groups are also failing to find a difference in terms of ASL measures of hippocampal blood flow compared to healthy controls and comparing to healthy controls and first episode patients. Stefan Heckers, who's also an alumnus of the Freedom Shell Clinic and MGH, recently found that hippocampal blood volume differed, but not hippocampal blood flow. So I think that whole issue is now a little bit up in the air. But the interesting findings, and this is a little bit complicated, so let me this is not yet published. This is just a first run as we were just looking at the data last week. So these are all fresh results. So this first column is the change in hippocampal blood flow compared to healthy controls. No effect of placebo as you'd expect. I'm sorry, not compared to healthy controls. So compared to baseline and then 2 hours after placebo, no significant change in hippocampal blood flow. With the lower dose, there was a change but didn't reach statistical significance. On the higher dose of 500, there was a significant reduction in hippocampal blood flow. So that finding, this significant reduction in hippocampal blood flow, was the reason we were allowed to go on to the large trial. We showed that we could correct or reduce hippocampal activity. The next column is, as a control, we looked at cortical blood flow, just as a control. Basically, we found that none of these drug conditions affected cortical blood flow. So it was specific to the hippocampus. And then the third column is, did the symptoms improve? And you see here, so this is BPRS total score. With placebo, there's a reduction in 9. With the intermediate dose, BPRS total score reduction of 17. So even this small sample, that was statistically significant. And then the higher dose decreased it by 12, which was not significant. So a pretty interesting and almost unexpected finding that this actually, after a single dose, was associated with significant reduction. But the dose that had significant change in blood flow volume was not the dose that reduced symptoms. And then, as you'd expect, this just shows that with increasing dose, we increased blood levels of levetiracetam. So in this slide, this shows that the reduction in blood flow correlated with blood levels of levetiracetam. So the squares are patients got the high dose, triangles are the lower dose, and circles are placebo. So this is just reassuring that it's a real finding, that as blood levels went up, the decrease in hippocampal blood flow decreased. Looking at what symptoms improved with the intermediate dose, the conceptual disorganization, hallucinations were both significantly affected. With the higher dose, only hallucinations were significantly affected. Grandiosity, can't really make anything of that. Basically, there was no change, but there was a greater reduction in patients who received placebo. So let me just want to thank all of the collaborators. Many people contributed to this. And this is the group in Shanghai, along with a couple members of my group who did a lot of this work. And this is Jijun Wang on my left, who made major contributions. So let me stop there. Again, I apologize, it's not clinically relevant, but at least I find it interesting. So I wanted to share it with you. Any questions? Yeah.
Your brain is like a heavy divided group. Because do you feel like the impairments in glucose metabolism contributing to the initial like brain volume decrease in certain areas? And like, for example, you showed that thought being with,
John, could you repeat the question?
Sure, yeah. So in terms of how the antipsychotics might be affecting brain volume, and given the fact that aripiprazole produced less brain volume loss, and given that aripiprazole has less effect on glucose and metabolism, could that be playing a role? And actually, Shadow probably knows a lot more about this than I do. The relationship between antipsychotics, insulin sensitivity, glucose metabolism is really complex, and that could play a role. Some studies have suggested relationships between, say, weight gain and response. Say drugs like clozapine and olanzapine that cause the greatest weight gain and the most insulin resistance have been associated with the best responses. Because of this interesting relationship, Shadow actually did 2 studies of intranasal insulin administration, which was a great idea, because that would sort of get at what you're asking. They were both negative. Shadow, are you convinced that insulin was getting into the brain? Was that a true test of that hypothesis?
Yeah,
Oh. Yeah, and I'll repeat what you said because here's a microphone. Yeah.
Thank you. Yeah, so insulin, I still believe insulin play a very important role in the brain, and so the negative studies we did with intranasal insulin delivery, I think it's more because of the delivery, the technical issue, and the delivery, the effectiveness. Yeah.
So then the question is, could that be playing a role? We actually didn't. I'm embarrassed to say we didn't have any measures of glucose metabolism among our biomarkers. We didn't even think to look at that, but that's a good idea.
one question, have there been any studies that measure using FTG, like any glucose uptake in the brain that's affected by
Yeah, so there's a we are all laughing because poor Dr. Rothschild's racing around the auditorium with a microphone, but there's a large literature on PET and glucose metabolism. And in terms of antipsychotics, it's a little bit complicated. It shows increased activity in the striatum. I've mostly been interested in hippocampal activation. There's some evidence of decreasing hippocampal activation. I realize we're out of time. And the very classic study by Stefan Hecker showed increased hippocampal activation at baseline, and patients were unable to further increase it. But there is a literature on that. Yeah.
So thank you very much for a very interesting talk. I'm good. Can I make one comment and get your thoughts on? So, I mean, it looks like it's still unclear, but I think we can say that maybe the antipsychotics do cause some loss of brain matter, and psychosis does as well. One of the conclusions in our STOP-PD study was if you're psychotic, you should take your antipsychotic. But it raises the question, if you're not psychotic, should you be taking an antipsychotic? And unfortunately, JAMA Psychiatry made us tone it down. So, but I wrote an editorial about that. If you're not psychotic, particularly, we've got 4 or 5 antipsychotics with an FDA indication for non-psychotic major depression. That's my new pet peeve, but I don't know if what you think about that.
Yeah, I agree with what you're saying. I think we can say that there's a high likelihood that antipsychotics in animal models and now in some placebo-controlled trials may be associated with some brain volume loss. Whether that's a bad thing or not, we can't absolutely say, but most of us would prefer not to lose brain volume. How to say that in a measured way, given that there's a major political movement now. I don't know if people are familiar with Robert Whitaker and Mad in America, but a whole movement on the web about antipsychotics are neurotoxic and psychiatry is really potentially evil and should not be trusted. And so how to get that message out in a nuanced way, because I think we'd all agree if someone's psychotic, the psychosis is much worse than anything that an antipsychotic could be doing, without discouraging people who get their information from these other sources and say, well, Doctors Goff and Rothschild are both saying, don't take antipsychotics, they're dangerous. But I'm trying to figure out how to get that message across in a way that would be balanced.
Thank you. Thank you very much.
Thank you.